Okay, good evening, everybody. I'll just make a start and introduce myself. So welcome to Williams Medical's first evening webinar. Thank you very much for taking the time to join us this evening. I'm actually the category manager here at Williams Medical. I look after everything medical equipment and pharmaceuticals. My colleague joining us today for technical is Kieran Stevens. He's going to support me to make sure everything goes according to plan. The webinar is in partnership with Omron, and we're delighted to welcome them here today with special guests. Just in terms of housekeeping, the scheduled time for the webinar is sort of set in for an hour and a half. You will notice the recording button is active during the event. We plan to share this evening's webinar on the Omron YouTube channel as well as internally for training purposes. Please let us know any concerns. For questions, please pop them into the chat and myself and colleagues will ensure that those questions are answered towards the end of the event. I will now hand you over to the Omron team. Thank you very much.
Thank you so much, Gavin. Good evening, everyone. It's a pleasure to be here tonight with our partners, Williams, and also with Dr. Yasir Javed, a GP with a specialist interest in cardiology, and Dr. Ravi Asamo, a consultant cardiologist. Without further ado, I'd like to hand over to them for our webinar. Thank you so much. Have a lovely evening.
Thank you very much. Well, good evening, everyone, and welcome to this webinar where we're going to focus on what I refer to as the silent killer. That is hypertension, one of the most potent risk factors we know of for cardiovascular disease. So we'll aim to discuss how to diagnose hypertension in accordance with latest guidance, and also touch on management. And then the second half of this talk, we're going to give a brief masterclass on how to manage arrhythmias from a primary care perspective, and we'll also weave in some of the new innovative portable ECG technology that may help streamline the diagnostic workup, again, particularly for those of us working in primary care. And we'll try and include an ECG interpretation section as well. And I'm joined by a really good friend, actually someone I've known from medical school, but has really developed into one of the great cardiologists in the UK, Dr. Ravi Asmal, and he's based in northwest London. So Ravi, a very warm welcome to you.
Thank you very much, Yasser. Delighted to be involved in what I'm sure will be an excellent series of talks, and I'm sure I'll learn a lot as well.
Well, Ravi, let's start off by getting your perspective on hypertension. I referred to it as the silent killer within cardiovascular medicine. Do you agree?
100%. I mean, I think I'm going to be 50 next year, and certainly on Monday when I had my insurance medical, I was absolutely alarmed to find my blood pressure being 175 over 100. I'm fully aware of the potential repercussions of this, and I've seen too many cases of kind of a slightly elevated blood pressure being ignored, kicked down the road, and in essence, these patients will present a decade or so later in extremis with consequences that could have really been prevented by nipping the problem in the bud. There's plenty of evidence-based, high-quality treatment that can treat hypertension and minimize the risk of the cardiovascular complications. So really the battleground for this is in primary care. You have all the patients, and certainly in secondary care, we don't want to be seeing these patients with the kind of end stage results. So I'm very keen that in the next hour and a bit, we kind of get across the key learnings that I've certainly learned working with you over the last few years with respect to managing this condition.
Well, thank you, Ravi. Would also like to acknowledge Omron, who in conjunction with Williams have very kindly supported the running of this webinar. As with all the webinars that Ravi and I get involved with, though there's been no external influence on the content of this webinar. It's going to be our personal perspective on this real critical area of cardiovascular medicine. Here's the agenda. We'll kick off with a sort of case study looking at the consequences of a late diagnosis and suboptimal management. Then we'll just reinforce the current guidelines and what is expected of the modern hypertension management protocol. And then a quick focus on arrhythmias, and we'll give you an ECG interpretation framework. And then we'll end with some key messages. We'll have plenty of time for Q&A at the end, and we'll aim to wrap up before 8:30 in the evening. So let's start off with the case study. A typical case study. It's actually based on a real case encountered in my locality of a 71-year-old male patient who had been gradually becoming more breathless over the previous few months. In fact, so much so that his GP actually arranged for him to be admitted. During his admission in hospital, he was diagnosed with HFpEF, or heart failure with preserved ejection fraction, and the echo findings that resulted in that diagnosis showed a severely dilated left atrium and severe concentric LVH, or left ventricular hypertrophy. So Ravi, over to you. Just make sense of these findings for us in primary care.
Yeah, so this is a kind of a devastating admission. This is a patient with heart failure with preserved ejection fraction, for which treatment options until very recently were almost non-existent. And in essence, this is completely avoidable. Heart failure with preserved ejection fraction, for me, means this is untreated hypertension over many years. And you've got all the hallmarks, the evidence is there. Severe concentric LVH, the left ventricular hypertrophy, takes many, many months, years to form, and can only do so if hypertension is left untreated. And what that results is the heart muscle gets thicker, stiffer, the pressure inside the left ventricle, the filling pressure rises. That has the effect of raising left atrial pressure, and you get a dilated left atrium. And a dilated left atrium is an absolute perfect substrate for potential life-changing arrhythmias such as atrial fibrillation. So the two conditions, hypertension and atrial fibrillation, go hand in hand. And the severely dilated left atrium, to me, as the cardiologist says, this chap, we need to be looking for atrial fibrillation in this gentleman with a 12-lead ECG, and if there's nothing found there, then with ambulatory ECG monitoring.
Yeah, so thanks, Ravi, for that. I mean, a really devastating condition to diagnose. I mean, he's still fairly young, 71, and we know that heart failure potentially, if picked up late, has a prognosis worse than many cancers. And sadly for this patient, he did have a tragic trajectory with multiple recurrent heart failure admissions. This is fairly common in patients like this over the following 6 months after diagnosis. And sadly, but not surprisingly, he died 6 months after this initial presentation. So we're really faced with a pretty tragic case of a patient who was actually previously fairly fit up until he started developing breathlessness a few months previously, now with a very premature cardiovascular death, and probably lost many good quality of life years, many years spending time with his grandchildren, enjoying the fruits of his retirement. So the key question that we're going to try and uncover throughout this presentation is, was this a preventable event? And I think Ravi's already alluded to the fact that this is highly likely. So if we go back in time in this patient's history, he actually had multiple cardiovascular risk factors. And Ravi, if I can just get your opinion on the type 2 diabetes. I've noticed in the European Society of Cardiology guidance now, anyone who's had diabetes for over a decade is now automatically classified as very high cardiovascular risk. Is this a very prevalent comorbidity in your cardiology clinics?
Yeah, so I'd say very comfortably around 20 to 30% of the patients we see have diabetes. But actually, cardiologists now have re-engaged with the concept of diabetes. 5 years ago, I didn't know what normal range for an HbA1c was. I'm now proactively looking for diabetes. Whether an HbA1c is part of our standard workup when we see patients, and we're actually the 20 to 30% that we see isn't the whole story. There is clearly a significant cohort, sub-cohort of patients out there who have undiagnosed diabetes. And every week we're making a new diagnosis, not as GPs, not as endocrinologists, but as cardiologists, because HbA1c with a diagnosis of diabetes completely changes the risk of that patient and brings in lowers your threshold for a whole load of treatments and interventions.
Yeah, and the other risk factors that were clearly present in this patient prior to his demise was the central obesity. We sort of almost think of this now as an inflammation factory that can very much accelerate things like atherosclerosis and cause premature cardiovascular disease in itself. And a common comorbidity, Ravi, of obstructive sleep apnea. From a cardiology perspective, how important is that, or influential is that as a risk factor from the heart's perspective?
It's absolutely massive, and it's completely missed. So, we're getting the hang of looking for and finding diabetes. We can see obesity in front of us, and we've got clear treatments for both those conditions. In our own service in London, we have now commissioned obstructive sleep apnea for patients with atrial fibrillation and with hypertension who you suspect have the body habitus that would result in sleep apnea. And actually with atrial fibrillation, we're trying our very hardest using lifestyle modification, including diagnosis and treatment of sleep apnea, to avoid expensive and non-prognostic treatments such as AF ablation, which are great for symptoms, but if you can get those symptoms treated by identifying contributing factors and treating those more effectively and more cost effectively, we genuinely believe that sleep apnea, the diagnosis will be increasing, and we'll be using a lot more of the novel sleep monitoring devices that have begun to become available since the COVID pandemic.
So with our sort of semi-forensic dissection of this case, we've already unmasked some pretty serious cocktail of risk factors that could have contributed to a really severe cardiovascular trajectory. But then we also found this finding in his notes of a diagnosis of white coat hypertension. This was actually diagnosed 15 years before his death. He was documented as having a normal ambulatory blood pressure at the time, but there was no further documentation of either home or ambulatory blood pressure monitoring, and his clinic blood pressure readings were consistently above 150 systolic, so significantly elevated, but without any sort of reassurance of normal home blood pressure readings. And he was on sort of monotherapy amlodipine 5 milligrams to sort of partially treat that. But the question to you, Ravi, really is, firstly, is white coat hypertension a completely normal phenomenon? And also, how do we get around this false reassurance sometimes of this label of white coat hypertension?
Well, you're speaking to a white coat hypertensive. As I mentioned at the beginning, my blood pressure was found to be grossly elevated during an insurance medical where I was anxious. I've subsequently been using my blood pressure monitor religiously for the last week, and thankfully my blood pressure is just within target limits, so I can avoid antihypertensive for at least another year or so. But I know that as a white coat hypertensive, I am at greater risk of developing bona fide hypertension. So every 6 months or so, I embark on a home blood pressure monitoring exercise where for a week or so, I will take blood pressures in the morning and the evening. It all Bluetooths to my phone. I can then look at it and make a decision whether the time has finally come for me to start taking medication or whether I can try other things. So it's not a benign diagnosis. Equally, we shouldn't, as I'm sure you're all aware, jump for the prescription pad and start doling out antihypertensives on clinic readings. So I think a home blood pressure monitor is actually an ideally a 24-hour blood pressure monitor is what should be offered, and frankly, at the very least, annual assessment to ensure your white coat hypertension has remained truly a white coat phenomenon and hasn't progressed to bona fide essential hypertension is entirely reasonable.
Yeah, but sadly that wasn't done in this case. I think the white coat hypertension is as I say, a falsely reassuring documentation in the notes that prevented us from identifying his blood pressure, which in the context of this sort of cocktail of cardiovascular risk factors was a really lethal mix, to be honest. It's hypertension, we know, particularly in patients with type 2 diabetes, really does accelerate that downward cardiovascular trajectory. And it is atherosclerotic cardiovascular disease that remains the single biggest global killer. It's actually one of the leading causes of dying prematurely in both men and women. Actually, far more women die prematurely from coronary artery disease than they do from breast cancer, for instance. So this is, I think we have to assume, almost part of the normal aging process. To varying degrees, all of our arteries will fur up with this process. The key is how quickly. And in order to identify how to potentially reduce the speed of progression, we need to understand the risk factors. Now, clearly, there are non-modifiable risk factors that unfortunately Ravi and I share most of, age, sex and ethnicity, that we can't do anything about. We're all familiar with the modifiable risk factors. And Ravi, do you agree that you touched on lifestyle interventions? Should that always be the foundation of any sort of cardiovascular prevention strategy? There's no tablet that can replace the virtues of healthy living.
No, healthy living, lifestyle first has to be the approach. I mean, the problem is, as a population, as a healthcare population, we have not embraced prevention. We have been very reactionary, and at long last, I think really more driven by the cost argument. I think we are beginning to hear the right things. So even then, my practice has only changed the last 2 or 3 years of the kind of the time I have for consultations, and working predominantly in the private sector. I have the luxury of far longer consultation times than I would in the NHS. I actually spend a good third of my time focused purely on lifestyle, because it makes, and we have a lot of patients who we actually put on antihypertensives because they need it. The question I'm asked is, do I need to take this for life? And the answer is not necessarily. In those patients where there are multiple targets for lifestyle modification, we've got great vignettes of them transforming themselves with diet, exercise, weight loss, and actually rendering themselves symptomatic with hypotension, because suddenly that tablet that they needed for high blood pressure is overcooking things and getting them hypotensive. So we brought them off the tablet. So I don't think it's necessarily a tablet for life in those patients who have multiple targets for lifestyle. Lifestyle intervention is at least as good as one, if not two, blood pressure tablets in those patients with multiple potential areas where we can focus.
Excellent. And probably tied in with lifestyle is and the importance of trying to reduce central obesity. That's the obesity that's metabolically active and can drive a lot of bad outcomes from a cardiovascular perspective. I think we're all now acutely aware of the importance of aggressive, much more so than previously, aggressive lipid modification. We know CKD is an independent cardiovascular risk factor, and there's now a huge focus on the early detection of CKD and instituting an aggressive renal protection strategy. Diabetes itself, purely from the insulin resistance aspect, it very much accelerates the atherosclerotic process and makes it more diffuse. But really the big one for me, the risk factor that potentiates all the other risk factors is hypertension. And that is something that, as Ravi says, if we can identify and treat early, a lot of the damage is preventable. And this is what we are trying to prevent ultimately. Ravi, I've put this clearly post-mortem specimen of a coronary artery on here. Just explain what we mean when a patient has a cardiovascular event. What's exactly happening pathologically?
So this big black blob that we're seeing in this post-mortem coronary artery specimen is thrombus. And the reason you've got thrombus, you'll see this tissue here where you've got plaque rupture. There's this little fissure. And what happens is the body missenses this as injury and activates the homeostatic mechanism of coagulation, thinking that it needs to stop somewhere bleeding out. So you've got an inappropriate activation of a homeostatic mechanism that saves life if you're bleeding. And what happens is you get you get platelets aggregating, you get thrombin, you get this clot formation, and it completely occludes the vessel, resulting in an acute coronary syndrome and in certain patients, cardiovascular death.
The same process can happen in the brain, and you can end up with an ischemic stroke. So this is a really important slide because it illustrates the most common cause of death globally. Obviously, you've got to die of something, and maybe it's not necessarily a bad thing if this happens in your 80s or 90s. But what we don't want to see, and sadly, it is one of the leading causes of this, premature death due to an acute cardiovascular event. And it's the very reason actually why NHS England have actually identified cardiovascular prevention as the leading opportunity to not just save lives, but reduce health inequalities. But embedded within that cardiovascular ambition is the importance of hypertension, to diagnose it earlier, to diagnose it more accurately, and also to make sure patients who are diagnosed are treated to appropriate targets as per national guidelines. And we know that hypertension very much accelerates your risk of vascular mortality. If we take, say, the sweet spot blood pressure of, say, 120 to 130 as your baseline, every 20 millimeters of mercury increase from that, you're seeing essentially a doubling of cardiovascular mortality. And so let's remind ourselves as to what the NICE guidelines, which were updated in August 2019, tell us about the diagnosis and management. And most of this, as Ravi says, is very, very relevant to our routine clinical practice in primary care. So just some of the key highlights. Ravi, NICE very clearly state to establish a diagnosis, clinic blood pressure readings alone should not be used to diagnose hypertension. What are your comments on that?
100% agree. I mean, I would have been diagnosed with hypertension many times over from a very young age, if that was the case, and inappropriately diagnosed. And then you treat patients with antihypertensive, they get side effects because actually their blood pressure is too low. So absolutely, you should not be. And I think home blood pressure monitoring is an absolute must. Ideally, ambulatory blood pressure monitors are, in my opinion, gold standard, but clearly resource is an issue here. And I think the other thing I'd say is with home blood pressure monitors, it's important that a patient is given advice that they procure a good quality device that has been kind of endorsed by the British Hypertension Society. There's no point digging out a device that's been sat in a drawer for 10, 15 years. It's not being calibrated. It's probably, the readings are probably even worse than what if you use those to actually make a diagnosis of hypertension. So good quality home blood pressure monitoring from a BHS validated device is the right thing to do in the event of a elevated clinical blood pressure reading.
Ravi, you mentioned that ambulatory blood pressure monitoring is your preferred method for diagnosis. So we're not talking about monitoring of existing patients with hypertension. Clearly, there are resource limitations that would make ambulatory blood pressure monitoring prohibitively expensive and just not sustainable. But in terms of the diagnosis of hypertension, the key, it's key to get that diagnosis right. Can you explain the virtues of using an ambulatory blood pressure monitor, and also just touch on the importance of sort of nocturnal readings?
So with an ambulatory blood pressure monitor, you get up to 40 readings over a 24-hour period, every half hour during the day, every hour at night. And what it does is it gives you, I mean, your blood pressure is like your heart rate. It will vary minute to minute, hour to hour, potentially even second to second. And what a 24-hour blood pressure monitor does, it gives you a very clear trend as to what your average blood pressure is. And it also allows you to ascertain the kind of health of the vascular system. What we should see is your blood pressure dropping at night because you're relaxed, you're sleeping, you've got increased vagal tone, your blood vessels should be more compliant. And if you don't see that, even in the context of an average normal blood pressure, that's a sign of arterial stiffness and increased cardiovascular risk. So you get that information absolutely critically. And I think even in some patients, we've had patients who get so anxious every time they check their blood pressure at home that their home blood pressure readings probably have a white coat element on it. And we have had a few cases where we've actually had to be absolutely certain with an ambulatory blood pressure monitor after home blood pressure monitor readings revealed similarly very high high recording. So I think as a baseline, it's a very good test. But I think if you're going on, if you're monitoring, so someone you've made a diagnosis of hypertension, you want to assess their response. You can't keep doing ambulatory blood pressure monitors on them, and that's patently ridiculous. I think you encourage them to invest in a good quality BHS endorsed blood pressure monitor, and to take diaries of weekly readings, 7 days, morning and night, and use that to assess how their blood pressure has responded.
So Ravi, I forgot to reinforce to the audience, please do, we want this very interactive, so please do fire in questions or comments as you feel necessary, and I'll try endeavour to address them with Ravi throughout this webinar. But there's a really good question that's just come in. The guidelines state that we use the daytime readings to establish a diagnosis. So Ravi, the question is, if you've got normal daytime readings, but the patient is a non-dipper, they don't have this 20–30% physiological drop at night, what should we be doing with these patients in primary care?
So, I mean, all the data for hypertension, all the outcome data is based on daytime readings. So the daytime, to be frank, there are some people who refuse to wear these monitors at night. I don't know if any of you have had a 24-hour blood pressure monitor. It's not the most comfortable thing. And I'm relaxed about that because I know all the data is for the day. But if you do see non-dipping, these are the patients who are clearly at greater risk. And you've got to, and I work them up very, very highly, make sure they're not diabetic, make sure there's no sleep apnea, make sure that the lipids are controlled. And to be frank, my threshold for treating them pharmacologically is far lower. Obviously we'll adopt lifestyle, but I almost consider this as a sign of end organ damage, the lack of dipping at night. So it does provide useful data. Conversely, there are some patients who absolutely refuse to wear this at night, but actually they make up the surprising minority. The vast majority can and do wear these devices overnight.
Right. So look, we're making the case that for diagnosis, if you do have access to ambulatory blood pressure monitoring, that is the preferable means for diagnosis. But if that's not available, then home blood pressure monitoring is a more than suitable alternative if ambulatory blood pressure monitoring is not available, not tolerated. And Ravi, in terms of making an assessment, we don't want patients to be preoccupied by taking their blood pressure sort of every day of the year. The NICE guidelines say 2 readings per recording, and then you do that twice daily, ideally for 7 days. So you end up having 14 recordings. Do you agree with that? And if so, how often should patients be doing this if they're stable?
I 100% agree with that. I'm now on day 6 out of 7 of doing my own. And it's looking good. So unless I have hypertensive spikes today and tomorrow, I should be underneath the threshold. But what I would do is, for myself, I'd repeat this in 6 months and in another 6 months. And if I have 2 6-month readings that are absolutely fine, I'd probably move to a year. But I think, me being the person I am, I think every 6 months it's a good thing to do.
Excellent. And we're just going to very quickly move on to the SPRINT trial, because it probably was the biggest landmark trial we've had in terms of an interventional trial in hypertension. It was essentially looking, slightly controversial, but looking to see whether there was any cardiovascular benefit from aiming for a bit more of an intensive target of less than 120, which I think some of us would be a little bit concerned about because of the potential side effects, versus 140. It was a high-risk primary prevention population. Diabetics and prior stroke patients were excluded because they just wanted to include really your bread and butter routine high-risk primary prevention. Over 9,000 patients. It was a multi-center study in the USA. And here you can see the 2 treatment arms. The standard treatment, you can see patients were pretty well controlled, just below 140, and in the intensive arm below 120. And Ravi, we've got to take a pragmatic approach on this. I guess the results did show a statistically significant reduction in major adverse cardiovascular events for the intensive treatment arm, but this should be very much bespoke, shouldn't it, to the patient in front of you in terms of whether they can tolerate this?
Absolutely, and I think this is something where there is a clear difference across the pond. The Americans tend to treat more aggressively, and to this low limits. And, and it could be argued with very good reason. I've become aware of recent data presented where actually more intensive treatment of high blood pressure, unsurprisingly and biologically very plausibly, results in less dementia, which is another major fear for so many of our patients and for all of us in general. However, there is nothing comes without a cost, and the data from this trial clearly shows a greater risk of side effects and complications relating to hypertension. So I think you do have to, if you've got a patient with multiple risk factors, certainly your diabetic patients, intensive treatment has to be your go-to. But equally, you have to accept that not everyone will tolerate that level of intensive treatment, in which case you revert to standard treatment. I think as time goes on, we'll probably meet somewhere in the middle, and certainly the Europeans are probably heading in that direction. So let's see what happens. But there is merit in a cohort of patients who are at high risk and who can tolerate the medications to really go for that intensive treatment.
Yeah, I think the key words tolerate. If you can, there is benefit, but many patients may not be able to. And the other key message from this trial, Ravi, that we're not going to get to, in your hypertensive patients, unlikely you're going to get to even the standard treatment target with just monotherapy. Most patients needed 2 drugs to get to a target of less than 140 and closer to 3 drugs on average to 120. So are we now in an era where we can categorically state that monotherapy for hypertension, for true hypertension, is likely to be inadequate therapy?
Yeah, I mean, I think we all know, we all treat hypertensive patients. It's very rare that one medication will get them to target. And all I find is that maxing out the dose of one medication, you get most of the benefit. Let's use amlodipine as an example. My personal experience with amlodipine is 5 milligrams is generally excellently tolerated. I haven't really come across many people who have an issue with 5 milligrams, and it gets their blood pressure down very nicely. But doubling it to 10 milligrams doesn't get their blood pressure down a whole load more. What it almost guarantees is swollen ankles. So I actually never go above 5 milligrams for amlodipine, because when I have a newly diagnosed hypertensive, they're grade 2, I will always treat them with 2 antihypertensives at a low dose. And actually, I will treat them with 2 antihypertensives at a low dose, not a low dose, at a modest dose, but in 1 tablet, because that's actually what the European Society of Cardiology guidance suggests, that you use combination therapy. I'm Indian by heritage, and in India, you've got a fantastic range, and we have for many, many years, a range of combination tablets. So antihypertensives, aspirin and statin and ezetimibe, aspirin and clopidogrel. It's very much embraced because you're reducing pill burden, you're increasing the likelihood of compliance, and compliance is a massive issue in those patients with uncontrolled hypertension. The reason, in a significant proportion, the reason it's uncontrolled is patients are not taking their tablets. So you give them 1 pill with 2 medications, you're far likely to get them to target with the first prescription. I accept that in the UK currently, the 2 major combination tablets we use, Sevicar, which is a combination of amlodipine and olmesartan, and X4, which is a combination of amlodipine and valsartan, are not generic drugs. They are branded and come at a price point. So this is something, again, we just need to work. We need generic, cheaper formulations of these medications, and we need to embrace them. So for me, my practice as a cardiologist is, if I'm prescribing an antihypertensive therapy, it's 2 drugs in one pill.
Yeah, and I agree with you. It's unfortunate that in this country, compared to continental Europe, compared to the subcontinent, combination treatments just for whatever reason have never really taken off. So let's look at the NICE guidance for recommended targets. So they have an age sort of cut-off target, but obviously this is a clinical guidance. Clinical judgment should be factored in. 135/85 is the default average home blood pressure target, but to rein it in patients who are over 80, I mean, I think probably more so frailty than age should be your determinant in terms of whether to sort of rein it in. And then the European Society of Cardiology, as Ravi alluded to, is a bit stricter. they've sort of gone for 130/80 as the default, particularly in high risk patients, and they identify patients who've had a sort of high risk of stroke or particularly patients with diabetic kidney disease. We really should, as a default, be sort of more aggressive. And just on that front with diabetes, we've known this for some time, that actually modest reductions in blood pressure in patients with metabolic disease results in far greater cardiovascular benefit, for instance, than significant reductions in HbA1c. So even in diabetes now, we're being a lot more holistic and broad and moved away from sort of a largely glucose-centric prevention strategy. And then moving on to the risk factors for developing hypertension, Ravi, genetics play a massive role, don't they? And there's also huge ethnic variation. Do you see that a lot in your clinics?
Yeah, so we see patients who are relatively young with hypertension. One of the first thing I ask is, does hypertension run in your family? You will see families where everyone's hypertensive, and has been so at a young age. And obesity is obviously huge risk factor. So even the medications that are now successfully being marketed for obesity clearly have an antihypertensive mechanism of action, in part that results in some of the fantastic outcomes they seem to portend.
So, Ravi, just clarify, what type of obesity are you more concerned with your cardiology hat on? I mean, BMI is a pretty crude assessment. What do you think of waist measurements?
Yeah, I mean, BMI is crude. Most personal trainers will have a elevated BMI because they carry a lot of muscle mass, but that's not a bad thing. What I actually think we certainly, what I now have, as well as a stethoscope and blood pressure monitor on my desk, I also have a measuring tape, because what I want to measure is abdominal obesity, which is a good marker for visceral fat, which is the dangerous fat that is associated with the metabolic syndrome. And I think that is a target that we should be looking for. We should be asking about height and weight. Sure, we always have done. We should also be asking about kind of waist size when it comes to trousers. So yes, this is again something that we're becoming more and more aware of, and certainly even as cardiologists, it's not something that all of us are routinely asking or looking to target.
Right, and then I've just listed some of the other known risk factors for essential hypertension. We won't dwell on them individually, but just make sure that you've taken a good alcohol history. Alcohol is strongly associated with having a high blood pressure. And actually, the European Society of Cardiology guidance gives a very useful table with graded evidence base in terms of lifestyle interventions for hypertension. Ravi, I always recommend salt restriction. I note the ESC now give a Class 1A recommendation for this, and they actually reinforce that the benefit is likely to be greater in Black people, older patients, and patients with sort of diabetes and metabolic patients. So that probably should be incorporated into our sort of routine counselling. Now I want to focus on the consequences of hypertension. I think we're all aware of the retinopathy, the damage to the kidneys, but obviously being a cardiologist, Ravi, I want you to really highlight the target organ damage that can occur within the heart. So if you just firstly tell us describe what we're seeing on our screen. It says a normal left ventricle here. I'll help you by annotating the chambers.
So the first thing to say is, cardiologists being cardiologists, we like to do things slightly counterintuitively. So you'll see the left ventricle is actually on the right side of the image, and the right ventricle on the left. The left ventricle here is labeled normal because of three key things. One is it's normal in size, it's not enlarged. The second thing is the wall thickness, which we're seeing in the left ventricle is within normal limits, up to around 11 millimeters. And the third thing is it's squeezing and pumping blood out in an appropriate and vigorous enough fashion. We call this the ejection fraction. Every kind of heartbeat of the left ventricle should pump out around 60% of your blood. That's what we call the normal ejection fraction. So this is what a normal left ventricle looks like.
So we're now going to subject this heart to 10 years of poorly controlled hypertension. The patient was asymptomatic for most of this period. but obviously with systemic hypertension, that left ventricle is going to have to pump against a much higher sort of afterload. So let's see what happens to the heart, and let's give Ravi the opportunity to describe the changes that occur within the heart.
Yeah, so I think hopefully all of you can spot the difference here. Like your biceps, if you keep doing biceps curls with resistance, you're going to get hypertrophy. And this is what's happened to the heart muscle here. If you've got heart contracting against increased afterload due to increased blood pressure, you get hypertrophy of the heart muscle. Now that's not a good thing, because all that happens is you get interstitial fibrosis, scarring of the heart muscle. That gets the heart muscle stiffer, and as the heart muscle stiffens, you get buildup of pressure in the left ventricle, which propagates backwards into the left atrium, and as a result, you get pooling of blood and signs and symptoms of heart failure. You'll notice that actually the ejection fraction, the amount of blood being pumped, ostensibly looks very similar. Actually, the heart on the right appears to be, from a radial perspective, pumping blood quite nicely, but the eagle-eyed amongst you may notice that actually there's something not right in the overall contraction. There's very little longitudinal movement. On the left, you'll see that when the heart contracts, it's also contracting, as well as contracting radially, it's contracting longitudinally. And a hallmark of left ventricular hypertrophy and heart failure with preserved ejection fraction, these two go hand in hand, is a loss of longitudinal function due to stiffening of the heart muscle.
Yeah, and we can illustrate that hypertrophy with this sort of still image. So this is the heart in systole, and you can see a very thickened interventricular septum as compared to the normal left ventricle. So I think, Ravi, this is fair enough. If this is a devastating consequence of chronic hypertension, do you think we should be hunting for this? You know, I'm not saying frequently, but at least potentially periodically getting an ECG to identify this target organ damage, because if we do find it, presumably it gives us even more reason to be more aggressive in terms of blood pressure control.
Absolutely, there's a tendency to kind of turn a blind eye to slightly elevated blood pressure. You know, go and do this, go and lose a bit of weight. But if you've got left ventricular hypertrophy, that's end organ damage. You have to be aggressive here, and I think it's very reasonable to do this. And also, the other thing about left ventricular hypertrophy is it's actually reversible, both on echo and ECG. And we've got lovely cases of newly diagnosed hypertensives. Clearly, it's been around for a while. They've been undiagnosed for many years, and we've put them on treatment, and we do serial ECGs, and it's great to see for the patient. It certainly motivates them as they see every time they have an ECG, the changes that we see at baseline are beginning to regress. So this is a reversible condition and something that can be tracked with an annual ECG or 6 monthly, depending on how frequent your reviews are for these patients.
Talk us through, Ravi, the ECG changes. I mean, you always mention that you should never look at an ECG without clinical context, so that is key. But let's just assume this is a completely asymptomatic patient who's probably had a very late diagnosis of hypertension. This is his ECG. What are the findings on here that may point towards a diagnosis of LVH?
Yeah, so the key findings, there are two things you need to look at. One is the voltage, how tall the complexes are. And you look at two leads. You look at V1, it's all of the kind of precordial leads. And then you pick the taller of the two waves in V5 and V6. Now, really, V5 is taller, but it's just for the purpose of this talk, we can't even see it. So we're going to pick V6. And then you count the number of large squares of the R wave in V6 and the number of large squares for the S wave in V1. So the downward deflection in V1, the upward deflection in V6 or V5. And if you summate them and the number is greater than 7, you have voltage criteria for left ventricular hypertrophy. So 7 large squares or 35 millimeters greater than is your voltage criteria. But that's not enough to make the diagnosis of left ventricular hypertrophy. You've got a very slim individual with a slim physique, you may get voltage criteria. But to make the diagnosis of LVH secondary hypertension, you need to have strain criteria as well. So if you look at leads V5 and V6, the lateral leads, and also 1 in AVL, you'll see that you have ST segment and T wave changes that we call strain, these lateral repolarization changes, ST segment and T wave changes. So you need to have voltage and strain criteria to document someone as having left ventricular hypertrophy. And as Yas has alluded to, it has to be in the correct clinical context. If this patient has completely normal blood pressure readings and has always had normal blood pressure readings, hypertension is not the cause. It's probably something else like a cardiomyopathy. Or if this patient has acute chest pain, this is an acute coronary syndrome. But in the given history here of a newly diagnosed hypertensive patient who's asymptomatic, this is LVH secondary to hypertension.
We've just had a question in, Ravi, from the audience. Completely asymptomatic patient, we do the ECG and you see findings like this. What's our next port of call? Do we need further imaging on this patient? You're on mute.
You should definitely be getting an echocardiogram to actually formally confirm and quantify the degree of hypertrophy. And sometimes hypertension can coexist with other conditions such as cardiomyopathy, so that's another reason to do it. And this patient needs to be treated really aggressively. And I think it would be reasonable to say, as a cardiologist, these are the primary care correctly, appropriately manages the vast number of hypertensives in the community. But I don't think it's a bad call to, I don't know what you think, Yas, to refer this on to secondary care for kind of specialist assessment and ongoing monitoring. This is dangerous. We want this treated aggressively, promptly, and ideally the LVH regressing.
And I agree. I mean, this is a worrying ECG. As far as I'm concerned, this patient's well on the way potentially to developing that devastating clinical syndrome of heart failure with preserved ejection fraction. And just another quick example, as Ravi says, that clearly this patient has voltage criteria. It doesn't matter whether you use V5 or V6. That is clearly voltage criteria. And this time, even more extensive sort of strain pattern seen in the lateral leads, one V5, V6, but also some of the inferior leads as well. So really important, in my opinion. I'm on a bit of a crusade in primary care. I don't think we do enough appropriate ECGs, and I think a really good use of ECG would be to periodically get one on your as part of the hypertension review in your patients, so you can pick up this early, hopefully early target organ damage and aggressively sort of reverse those changes with good blood pressure control. In terms of treatment, I'm going to very quickly take you through the current national guidelines, British and Irish Hypertension Society guidelines for the pharmacological management. So this should always be, as Ravi says, on a foundation of lifestyle intervention. But we know for patients with type 2 diabetes, I mean, hypertension and type 2 diabetes go hand in hand. ACE inhibitors or ARBs are the first line choice because of the added renal protection that these drugs give. For patients that are not diabetic, we have to factor in the age and ethnicity. And for younger patients who are not of Black African or African Caribbean origin in terms of ethnicity, again, it's an ACE inhibitor. For the older patients or patients of Black African or African Caribbean, it's a calcium channel blocker. But very quickly, and I completely agree with Ravi, I personally would follow the ESC guidelines. You probably should very quickly go for combination, or even start off with combination therapy where you combine the two. Add in the thiazide light diuretic is going to be required for many patients. If you're still getting nowhere with the patient's home blood pressure readings, it's always worth exploring compliance. Hypertensive drugs are probably some of the most poorly complied with drugs. The number of patients that tell me only, on deep questioning, that they only take their tablets when they feel their blood pressure is high is quite a common occurrence. But Ravi, there are some patients though whose blood pressure still is suboptimal despite good compliance on sort of triple therapy. And we know the guidelines very much advocate the use of spironolactone. But it's a drug that I don't see used very often in primary care for hypertension. But what's your view on using it in this situation?
Okay, so this is almost like magic dust. I've had many resistant three medications, including a diuretic, hypertensives. I've been absolutely rigid in making sure that their compliance is up to is not the culprit here. And you give them spironolactone, and it's almost like the hypertension disappears. And the reality is there is a proportion of patients who have a mild degree of hyperaldosteronism, and spironolactone is the magic key to unlock the problem. So it's definitely something that I'd say we started embracing it in the last 5 to 10 years. Is no reason why primary care shouldn't be reaching for this. It will save. You'll be absolutely stunned how much of an effect it has, and at a very low dose. You don't have to give huge amounts. Just 25 milligrams is really all we're looking at. And the more you use it, the more you like it. And certainly, I don't label anyone as a resistant hypertensive. The traditional definition has been 3 medications, including a diuretic. For me, it's you've got to have spironolactone in there, that 4th agent, before we start calling the patient resistant.
I mean, obviously, yeah, I agree with you. This should be used a lot more in primary care. Obviously, we need to keep an eye on the potassium, but in young patients with sort of healthy kidneys, you're unlikely to run into many problems using spironolactone, as long as you take the precautions in relation to potassium levels. Ravi, you, I think, like me, really like this neat study, which sort of almost answered that age-old question as to when is the best time to take your blood pressure tablets. So tell us about the time study and how it influences your clinical practice.
So this made me smile because it addressed a very simple question, and one that we've all been asked. And I think there was a study just prior to this that suggested taking your blood pressure at night it gave you better control. So everyone read it in the Daily Mail, and we were all inundated. All our patients on antihypertensive therapy were asking about whether we should switch at night. This very clearly demonstrated it makes no difference when you take your medications, providing you take your medications every day and providing you take them at the same time, which obviously biologically is completely sensible, plausible, and should not be surprising. But obviously, it took this big study for us to kind of figure out what was, in my opinion, blindingly obvious. Just take your tablets every day and take them at the same time. Doesn't matter. Well, and I think the advice I give to patients when I get asked what's the best time to take them, what I say to them is take them when you are most likely to remember or least likely to forget. And for some people it's the morning, some people it's the evening, a minority it'll be lunchtime, whatever it is, whatever works for you, do that. Yeah,
that should really help compliance. Just briefly, Ravi, isolated systolic hypertension. We see this sort of a lot in sort of older patients where the systolic's elevated, but the diastolic looks relatively normal. How do we manage these patients?
So you manage them as you would your standard hypertensive, but you accept that a proportion of these patients will not necessarily be able to tolerate the medications that you give your standard hypertension population, because as well as dropping their systolic, you're going to be dropping their diastolic, which may make them symptomatic. And you have to try what you can and get them to a best possible scenario. So getting their systolic as low as possible without unacceptable side effects. There are certain trials suggesting certain drugs are better in terms of systolic hypertension. I think I'm not overly convinced. And these kind of patients are sometimes the ones that you may actually want to get a blood pressure specialist to see in secondary care.
Ravi, you just had a question in actually. What about the opposite, patients with, it's probably less common, but isolated diastolic dysfunction, but a relatively normal systolic?
Yeah, so I mean, those are again, you tend to see them in the younger patients, and that's, we do see a lot of it, and a lot of this will be something that you can tackle with lifestyle first. If not, often antihypertensives will get them to target. Systolic is more of an issue. You tend to get more side effects by trying to get their blood pressure lower. The diastolic elevations tend to be modest and treatable with either lifestyle or antihypertensive or modest dose of antihypertensives.
So clearly the majority of patients with hypertension are going to have essential hypertension, and we can hopefully manage the majority safely and appropriately in primary care. But Ravi, just give us a flavour for the type of patients that you think may benefit from a referral to a specialist like yourself, in particular the ones that we suspect secondary hypertension. Also give us a flavour for the type of tests that you might subject these patients to.
Yeah, so the patients with secondary hypertension are the ones that you think there is actually a underlying hormonal cause or potentially a structural abnormalities in the blood supply to the kidneys or in the aorta. So what we tend to do is we tend to see young patients. The NICE guideline says consider it in patients under 40. Frankly, loads of 35, 30-year-olds will have high blood pressure due to poor metabolic health. So I don't think an age cutoff of 40 is particularly helpful. You're just going to be referring a whole load of metabolic, overweight patients who just need to optimize their lifestyle. For me, really, if you're in your kind of less than 30 with no obvious metabolic drive for your blood pressure and have quite marked hypertension in the absence of other family members having hypertension, those ones really raise my suspicion. And then there's your cohort of resistant hypertension, where no matter what you throw at them with respect to medical therapy, their blood pressure doesn't move, including your spironolactone. And in those patients, assuming they are compliant and you've excluded a lack of compliance, they are the kind of patients who we are most likely to find a secondary cause. What tests, as Yasser said, that we subject them to? Well, very simply, more blood tests and a urine collection for 24 hours. So we look for renin, aldosterone, cortisol, which are the key hormones implicated, as well as urinary catecholamines. We may also perform special MRI hypertension screening protocols that will look for, in one scan, will exclude renal artery stenosis with an MRA renal arteriogram, will exclude any structural abnormalities in the kidneys, will ensure there is no evidence of any adrenal tumors, will ensure there is no aortic coarctation. All in one scan, takes about an hour or so. But we tend to really reserve it. It's very kind of resource intensive. We tend to reserve those in patients who we are really suspicious have secondary hypertension, and specifically also have evidence of abnormal specialist bloods or urine collections. The bloods and urines are almost a gatekeeper to that specialist scan.
Brilliant. Right, let's change tack slightly. We know that palpitations are a very common presentation in primary care, and I guess a very common cause for referral to secondary care. So we're going to just briefly review how we should be tackling these patients in primary care. And if we go back to basics, a lot of this can be risk stratified very appropriately with a simple but focused history, a cursory examination, and a 12-lead ECG. And we should be able to really risk stratify these patients into sort of a traffic light system. Thankfully, the majority can potentially be managed safely in primary care, deemed to be at low risk with reassurance. So in terms of the history, obviously we're going to be asking about nature of palpitations. Patients describe palpitations differently. They can be fast, slow, irregular, forceful. So it's really helpful to spend a bit of time asking the patient to explain what they mean. I think onset and offset can give a real clue. If something starts very suddenly and stops very suddenly, far more likely to reflect a tachyarrhythmia. But Ravi, I've got some of these other issues highlighted in red because they really are red flag features. Can you please go through them and explain why these are very worrying features to find in a history of someone with palpitations?
Yeah, it's a lovely slide, and I think you summarise very succinctly the questions and the features of palpitations that you need to ascertain, really to identify those patients at high risk. Now, most people, when they describe palpitations, are describing benign ectopy, which tends to occur at rest when they're doing nothing at all and are not distracted, so lying in bed at night. If, however, these patients are getting palpitations with exertion, that suggests some form of provocable arrhythmia, and you've got to worry about SVTs or, God forbid, even VT. Clearly, pre-syncope and syncope suggests hemodynamic compromise, so some form of tachyarrhythmia or potentially even a pause, resulting in cerebral hypoperfusion. So that's a red flag. Clearly, one of the tests I consider essential for palpitations, and I think I'm sure this will not necessarily be agreed by all, is an echocardiogram. If you have a structurally normal heart, then you know that actually whatever history, for me, a normal echocardiogram is far more valuable than a normal 24-hour ECG monitor. You know that whatever palpitation or arrhythmia is unlikely to be of any prognostic significance. However, in those patients with heart failure or severe left ventricular systolic dysfunction, that level of scarring in the heart is a great substrate for ventricular tachycardia. So suddenly palpitations do not have that kind of benign flavor in patients with significant LV impairment. And clearly a family history of sudden cardiac death at a young age raises the possibility of an inherited cardiac condition, be it structural or an arrhythmic genotype. So those are the key things we've got to ascertain. So you have someone who has palpitations at rest, no syncope or pre-syncope, normal echocardiogram with no family history. This is a low-risk patient.
And just for completeness, it's very helpful sometimes to take a good drug history, recreational as well as pharmacological. Caffeine can be very much associated with ectopics, and also don't forget about the drugs that can influence the QTc. So I guess, Ravi, what the previous slide was really getting at in terms of those red flags was looking for red flags that could indicate or increase the likelihood that these palpitations that the patient's experiencing could be a substrate for developing a ventricular arrhythmia, which we know can sometimes degenerate into something very nasty and lead to a premature death. So the aim really is to exclude those ventricular arrhythmias, and that's the very reason why we really want you to systematically, in every patient presenting with palpitations, make sure that there are none of these sort of red flag features present. We're now going to move on to an arrhythmia that we've already actually touched on today, but I make no excuses for revisiting it because it is the most common sustained cardiac arrhythmia, and it is also happens to be the leading independent risk factor for stroke. We're going to show electrophysiologically what happens to heart in sinus rhythm and atrial fibrillation, and we'll give Ravi the opportunity to explain what's going on when a patient develops AF. And just to highlight, this is a very common transition. The lifetime risk of any of us developing AF is now thought to be in the region of around 1 in 3.
Yeah, so what you're seeing on the left is the electrical current in sinus rhythm originating from the top of the heart and the right atrium, from the sinoatrial node, the pacemaker of the heart, making its way down in an orderly fashion to the AV node, where there's a slight pause to allow the left and the right ventricle to fill with blood before going down the left and right bundle into the left and right ventricle. So you have coordinated pumping of the atria first and then the ventricles. And the atria are very much the pace setter, which telling the ventricles how fast to work. Conversely, with atrial fibrillation, what you're getting is a chaotic atrial rhythm that comes from all over the left and the right atrium, and they batter the AV node from various angles with a relatively high rate. And as a consequence of that, you get an irregular tachyarrhythmia typically, and a consequence of losing that atrial kick, that absolute atrial contraction, that kind of coordinated contraction, and instead of that, you're getting your atria just shaking around. You lose 20% of your cardiac output. So your patients, specifically your young patients, may actually get symptoms not just of palpitations due to tachyarrhythmia, but also due to dyspnea secondary to a loss of that atrial kick and that 20% of the cardiac output. The worrying thing is your elderly patient may not notice this because they're not necessarily as active, and they're walking around with a life-threatening arrhythmia undiagnosed because they haven't had these symptoms that have prompted them to declare themselves to a medical professional.
Yeah, and the other devastating consequence of loss of that atrial kick is the stagnation of blood that will occur within the atria. And Ravi, this is a real devastating consequence, isn't it, of atrial fibrillation? So to describe what we're seeing on this slide.
Yeah, I mean, this is a horrible, almost a sickening image of a big thrombus sitting in an outpouching. Now, this is done via a procedure called a transesophageal echo, where you basically swallow a probe, and that allows you to visualize this part of the left atrium called the left atrial appendage. This is a big thrombus. This thrombus can start forming within 24 hours of developing atrial fibrillation, so it doesn't take long to form. And you can imagine the consequences of this thrombus falling out of the pouch through the mitral valve here on the left of the left side image into the left ventricle and then northwards. And it's only going to go in one direction. It's going to be a large chunk of thrombus making its way up the carotids and then including a large conduit, the middle cerebral artery, causing a massive stroke, which if you're lucky, you won't survive. If you're unlucky, you will, but with unfortunately devastating consequences in terms of your ability to care for yourself and function as a human being.
Well, I like to think of atrial fibrillation management in primary care as it's almost like a race. We want to screen, diagnose, and anticoagulate patients before the stroke wins the race. Sadly, we know from quite recent data, unfortunately, that 50% of AF strokes actually occur as the first presentation of AF. So stroke is clearly winning the race very often. So we do need to try and think about strategies where we can expedite and really streamline the diagnostic workup of things like atrial fibrillation. And the ECG is the key test to diagnose atrial fibrillation. And Ravi, I've always thought the most important thing to identify in an ECG when trying to work out the rhythm is the presence of P waves. P waves are representative of this smooth atrial depolarization, and they really should be identical P waves on an ECG to show that regular atrial depolarization. And in this case, you can see clear P waves and every P wave followed by a QRS, also indicating no significant sort of atrioventricular block. And then in the patient, so my algorithm for assessing the rhythm is, are there any P waves? If the answer is yes, have a cursory glance to make sure every P wave generates a QRS, and that's your sinus rhythm with no high degree heart block. In atrial fibrillation, clearly you've lost that synchronicity of the atrial depolarization, so you don't get those regular P waves. You get a rather chaotic baseline often. And then the key thing, when you don't see P waves, you know the rhythm isn't sinus. You know the sinoatrial node is not in control of the heart. The key thing then is to look at the QRS rhythm. And if it's irregular, it can really only be atrial fibrillation. So to diagnose AF, it's really the absence of P waves and then the irregularity of the QRS rhythm. And Ravi, we're in an era now where I think there's a much greater appetite for adopting innovation in terms of not just ways of working, but also technology. I've noticed in the past few years a greater appetite for using portable sort of ECG devices in particular within the diagnostic workup. Is this something that you endorse?
Absolutely. I don't go anywhere without my Apple Watch because I've got nice Swiss watches I was given, but they're totally useless. They don't diagnose AF. The reason is that actually in a clinic late on an evening when you're the only one around, if you have someone with an irregular pulse, you can just take your watch off, put it on their wrist and make that diagnosis of atrial fibrillation. You can do it also with this device that Yas has put on the screen on a live call. I like the Apple Watch because actually patients can be sitting on their sofa and if they get symptoms, they can simply just touch the dial on their watch and get a single lead ECG tracing for 30 seconds, which you can email from your phone to your clinician, including yourself or your practice nurse, and make that diagnosis of atrial fibrillation. I think Yas and I have this view that if you go to an Asian wedding, always carry one of these around because you will almost definitely pick up atrial fibrillation. They tend to wheel out all the old relatives. And I've certainly found myself amongst friends and family. I have this habit of shaking people's hand with what I call the Vulcan handshake. I feel their pulse. And on at least one occasion, I felt an irregular pulse, put my Apple Watch on, made the diagnosis of atrial fibrillation, and from my phone, being able to issue an electronic prescription. So it's great to have the gadgets, and actually we've also got great cases where we've suspected someone has having runs of paroxysmal atrial fibrillation. You put a monitor on for ambulatory ECG monitor on for 14 days, and you've not captured AF because they've not been symptomatic. They've then gone and bought themselves an Alive Core, and in the case of the patient I'm alluding to, an Apple Watch, and then one day you get an email clearly showing atrial fibrillation because they've captured that arrhythmia. Because remember, you have to capture an ECG demonstrating it, and the ESC, the AHA, all the learned bodies fully state now that a 30-second single lead ECG recording is absolutely adequate to diagnose the atrial fibrillation. You do not need to go and confirm it on a 12-lead ECG. A simple 30-second single lead ECG is adequate.
It's clearly very obvious that Ravi's quite wedded to Apple technology. He spent the best part of the last decade trying to convince me to switch from my Samsung and Windows laptop to an Apple. But no, I think it's marvelous technology. But in areas, Ravi practices in a very affluent area. I'm sure he's got very affluent, many affluent patients. But I think just go with what's available. And I find the AliveCore a very cost efficient resource, portable ECG that you can just weave into your sort of routine clinical practice and make diagnoses. I mean, here we've got a clear diagnosis of a patient with no regular P waves, could be sitting in his living room, emailing you this PDF trace from his phone, irregular QRS rhythm, and a diagnosis of atrial fibrillation. The other thing we often pick up, Ravi, are ectopics, in this case ventricular ectopics, quite frequent ones in this particular ECG. What's the protocol for us in primary care when we see patients with frequent premature ventricular contractions on an ECG?
So, I mean, obviously take a history, figure out what may be triggering them. Often anxiety, caffeine, alcohol. Make sure there's no family history. Make sure they're not worse on exertion. So all your red flags. Make sure there's no family history, no prior MI, and then for that level of ectopy, I would get an echocardiogram to make sure the heart's structurally normal, and an ambulatory ECG monitor, not to tell you that they've got ectopy, but to tell you what the ectopic burden is and what the configuration is. Are they occurring in isolation, or are they occurring in runs of ectopy? And certainly runs of ventricular ectopy equals ventricular tachycardia. So we are keen to exclude that diagnosis.
And what about extra beats that are clearly supra ventricular in origin? So the atrial ectopics, you can see here we've highlighted with 3 arrows these extra QRS complexes that they're not preceded by a P wave. Are these less worrying than the ventricular ectopics?
I would say they are less worrying, absolutely. But a very large burden, 20–30%, may be a precursor to AS. So less worrying, but I wouldn't, if you're getting a small burden, certainly less than 10%, I wouldn't worry about it at all. But there is some suggestion to say that if you're getting a large burden, 20–30%, it may well be a precursor to atrial fibrillation.
Right, and now we're just going to end this sort of ECG segment with, some patients with palpitations will be experiencing tachyarrhythmias. So just Ravi, I know you love going through this sort of pretty systematic protocol for how to make sense of tachycardias on an ECG. So why don't you kick off with what to look out for?
Sure. So the first thing I'd say is tachycardias in a patient are often associated with symptoms. The patient may not be feeling well. When you're doing or when you're interpreting an ECG of someone with a tachycardia, my first rule is there's absolutely no obligation for you to become tachycardic. It's the patient who's tachycardic. You are simply trying to help them and figure out. And actually, the most common tachycardia in primary care is sinus tachycardia, which we all get. Certainly, every time I'm in front of a healthcare professional, I get tachycardic. I'm a terrible patient. The first thing I'd look at is the QRS width, and then figure out, is this the definition of tachycardia rate greater than 100? So when you have an ECG with a rate greater than 100, I kind of move to my tachycardia system. I will then focus on the QRS width, if it's narrow, if it's broad. If it's narrow, the next thing I look at is whether it's regular or irregular. If it's an irregular, narrow, complex tachycardia, this is atrial fibrillation. Obviously, you need to confirm no P waves. If it's a regular, narrow, complex tachycardia, the next thing you ask yourself is, can you see P waves? And if you do, that's the most common tachycardia in primary care in terms of ECG interpretation, sinus tachycardia. If you see no P waves, but it's regular, it's narrow, complex, this is a supraventricular tachycardia. Now moving on to the broad side, Broad complexes tend to be more worrying, and again, you adopt the same system. Is it regular or irregular? If it's irregular, you have a range of possible diagnoses, including atrial fibrillation with bundle branch block, or pre-excited AF or torsades. These are all a separate talk for another day, but this gives you a flavor. If it's regular, again, same system. Look, are there P waves? If it's P waves, it's sinus tachycardia with a bundle branch block, giving you that broad complex. If there's no P waves, it's a regular broad complex tachycardia. You have now got permission to become tachycardic yourself because this patient has ventricular tachycardia. Unless you do something relatively quick, it is unlikely that they will have a pulse in the near future. So that's our kind of system for interpreting tachycardias, and that's your real red flag, your ventricular tachycardia. Broad QRS, regular, no P waves.
That's the rhythm not to miss on your ECG. So let's look at this young patient who's quite anxious, not particularly clinically unwell with her palpitations. You managed to get an ECG at the surgery while she's having her palpitations. So if we use Ravi's algorithm, we can clearly see a narrow QRS width. It's regular in terms of the QRS rhythm. There's no sort of normal looking P waves. I mean, there might be some sort of hidden P waves, but we can't see any normal P waves. So this is your classic SVT. And Ravi, what's this rule about if you see a narrow complex tachycardia and you've got a heart rate of 150, think atrial flutter? How does that come about?
Yeah, so atrial flutter is basically you have the same risk of stroke compared to atrial fibrillation, but you've got a more kind of coordinated contraction. So your intrinsic atrial rate is 300 beats a minute. So with atrial flutter, what's happening is your atria are fluttering away at 300 beats a minute, but only a certain proportion of those flutter waves are getting through to the ventricle. And typically you have every other one being blocked. So every second kind of flutter wave being propagated. So if you have a rate of 150, what's happening is you've got atrial flutter with 2-to-1 block within the AV node. So as the atria are fluttering at 300 beats a minute, only every other flutter wave is propagated. So if you see a regular narrow complex tachycardia without P waves at a rate of 150, the three causes are 1, atrial flutter with 2-to-1 block, 2, atrial flutter with 2-to-1 block, and 3, you can safely say it's atrial flutter with 2-to-1 block. The way of actually, without kind of being glib, the way to prove it is in an emergency department. These patients can be injected with IV adenosine, which transiently blocks the AV node, and you will see the flutter sawtooth pattern becoming apparent. I'm not suggesting you do that in your primary care setting.
Excellent. So now just so that was a relatively benign clinical presentation, but here we got a 78-year-old. In fact, you don't really need an ECG to be thinking about an onward referral in this patient. So Ravi, this is a patient with known pretty significant ischemic heart disease. I mean, he's had a bypass surgery in the past. He's got a knackered left ventricle with an ejection fraction of 30%. He's even had VT arrest in the past. He's not feeling well. He's lightheaded. He's got pre-syncope, the sudden onset nature of his palpitations. And when we do his ECG, not surprisingly, but very worryingly, we see this broad, complex, regular tachycardia and no sort of P waves indicating the VT. So this really is a patient that should not be in primary care and needs to be assessed as a medical emergency in secondary care.
Correct.
So just to summarize those key points, when you're faced with a patient with suspected arrhythmia, palpitations, take a good history. That doesn't mean a long history, but take a good history. Don't miss those features that we reinforce. Always consider the red flags. I think always do a 12-lead ECG. Has great therapeutic value as well as risk stratification value. And try and correlate symptoms with an ECG trace. And for some patients, that will mean an ambulatory ECG. And as Ravi says, a normal ECG with a normal echo does put the patient in a very low risk group. And I think most of us would have access to these tests in routine clinical practice. But please don't miss those red flags, the exercise-induced nature of the palpitations, the syncope, the pre-syncope, and patients with known structural heart disease. And we're just going to end now with our perspective on some of the really innovative technology that can, we think, can very much help address unmet needs in cardiovascular prevention. I think we've made the case, Ravi very articulately reinforced how AF and hypertension are intrinsically linked. I mean, there's so many various mechanisms where we can see hypertension driving the development of atrial fibrillation. It almost makes the case, Ravi. I mean, what's your opinion? Should we be actively screening for AF in patients with known hypertension?
100%. They go hand in hand. I think in our patients with hypertension, we encourage them to monitor their blood pressure at home. I think there's absolutely no reason why they shouldn't be, with some of the devices we've alluded to, monitoring their heart rhythm. We already know that certain blood pressure monitors will kind of trigger off there's an irregular heart rhythm. It won't give you an ECG, but we'll tell you, and that often prompts the hunt for ambulatory ECG, the hunt for an irregular heart rhythm with ambulatory ECGs, etc. So definitely they are so closely linked that it would be a real missed opportunity, almost foolish not to screen for AF in someone with hypertension.
And just to reinforce, we're talking about the single leading independent risk factor for having a stroke, and also the strokes that occur with AF tend to be more devastating because they involve larger clots which block larger arteries, and therefore more disabling and a higher risk of mortality and morbidity. But we also know the opportunity is immense because we've got a wonderful preventative treatment, anticoagulation, which really should now be first line delivered with DOACs. And it's the very reason why AF is probably right at the forefront of that cardiovascular ambition. We talked about hypertension, but I still, in my opinion, it's the AF where that represents the biggest opportunity. If we can diagnose and anticoagulate before the stroke, we can prevent a lot of downstream devastation, not just in terms of human cost, but NHS and social costs. So, Ravi, very rarely do I see innovation where you just think, that is genius, where they've combined, two diagnostic modalities in one. So we've made the case that hypertension and AF are intrinsically linked. Clearly, there's a resource issue in terms of hunting for atrial fibrillation in these patients. But I know you're a great fan of this device. I know you bought one for your dad. I've got a couple now in my clinical environment. The Omron Complete device, which basically has that Cardia Alive Core functionality integrated within a blood pressure machine. So really at the time of a patient taking their blood pressure, he can also or she can also get a one lead ECG trace. I mean, what's your take on this technology?
That's absolutely fantastic. I mean, beautifully designed. I've used it, my dad's used it, and you can see on the panel on the right, you put your blood pressure cuff on as you're taking your blood pressure. Simultaneously, you're also taking an ECG. It should, I mean, to be frank, this should be the standard of care when it comes to home monitoring. You should be looking for everything. So yeah, it's the next, I suppose, the next challenge would be to reduce the size. But I think it's a great piece of kit. It's something that I advocate to friends, family, and to patients as well.
Right, now I fully endorse that as well. So I think we've answered pretty much all the questions, actually. Apart from one, there's one that's just come in, hot off the press. Ravi, you mentioned that half dosing, if not tolerated, was a way to go. But what about splitting doses? So there's a specific example. A lot of patients don't tolerate ramipril or an ACE inhibitor due to postural hypotension. Is there any merit in sort of splitting doses of ACE inhibitors, say 2.5 BD versus 5 in one go? Is that something that you do in your clinical practice?
Similarly, I've had anecdotal feedback that tends to work. There's no obviously randomized control study. We tend to, cardiologists tend to operate in an environment where we're always looking for the key study. But I think common sense dictates that actually, if 5 in one goes too much, why don't you try 2.5 twice a day and see what happens? You may get less side effects, but equally your blood pressure lowering may also still be maintained. So it's definitely worth a go. I think I sense in some people it will help, and some people they may get less dizzy, they may not, but it's definitely worth a trial, in my opinion.
Right, that now takes us to the end of time. Actually, this I mean the time really flew by for me. I want to thank the audience for your very kind attention. I hope you found this a useful learning experience. I think the reason I love doing these webinars, particularly with a wonderful secondary care colleague like Ravi, is you get those practical nuggets that you perhaps don't get from a textbook or a guideline. So I'd really very much like to thank Ravi for giving up his precious time, and hopefully you'll when you've recovered you might even want to come back and do another one of these sessions in due course. So I think if we can signpost back to the Williams medical team to give a final wrap up, and Ravi, I think we've taken up way too much of your time. I'm very happy for you to log off, and we'll leave it to Williams to wrap up.
Similarly, thank you, Yasser, for involving me, and thank you for the audience for their kind attention.
Thank you very, very much, and thanks for everybody for staying right until the very end. It's an absolutely fantastic presentation this evening. I'm certainly not a salesperson. I'm just going to give you a quick couple of slides just to demonstrate what we are trying to do with Omron and get the best value for money out into primary care. The Omron Complete, as mentioned, just an absolutely fantastic device. We are selling the device the cheapest in the market. I can see it's probably about £50 cheaper than what you can even see on Amazon at the moment. And just for joining us this evening, we can also offer an additional 5% off the Omron range just by using Omron 5, either on our website or by giving our contact centre a call. There's also some information just there in the slides, which will be shared either tomorrow or Thursday morning, just around the Omron Night View for a more direct-to-consumer level. And just onto the next slide, please. Just a quick overview, really, of the full range that we supply working with Omron. You can see that we've really tried to get the prices down, again, to support primary care. We understand the challenges that are happening at the moment, specifically with funding and spend. And again, Omron 5 will give you a further 5% off the complete Omron blood pressure monitor range. And just to finish off on the next slide, for those of you that don't know us, we have been in business for a number of years. We do everything from disposables through to pharmaceuticals, very strong in women's health, specifically within IUDs, which we know there is an issue with copper shortages at the moment. What does set us apart is our services, and we can support with new build and refurbishments, as well as care plans, servicing, test and calibration services. Important to us, and what's really started in the last few months is events such as this, which is really important to us. By way of example, on the 29th, we will be showcasing a new daytime event on the fundamentals of COPD management. Please check out the webinar link on our homepage. And really just to follow up with the final slide, a really big thank you for this evening. We will share the slides and the video probably, if not tomorrow, probably Thursday morning from ourselves and Omron. A really big thank you and good night.